All right, welcome to this explainer. If you're a medical trainee, you know that huge, kind of scary differential for shortness of breath? Well, today we're going to build a really clear, practical framework for one of the toughest parts of that list, diffuse parenchymal lung disease.
So let's just jump right in with a scenario you are absolutely going to see. A patient shows up, they've been short of breath for months whenever they try to do anything, and they've got this nagging dry cough. This classic story should make a little bell go off in your head. You got to be thinking about the lung tissue itself.
And that's exactly what DPLD is. It's not just one disease. It's this massive umbrella term for over 200 different conditions that all lead to inflammation and scarring, fibrosis, right in the delicate parts of the lung where oxygen gets into your blood. Our mission today is to give you a system to make sense of all this chaos. So here's our game plan. We're going to start with the diagnostic tools you need in your belt. Then we'll split things into two big buckets: DPLDs, where we know the cause, and those that are idiopathic or unknown. And then we'll wrap it all up with the key takeaways you can bring with you to the wards tomorrow.
Okay, so where in the world do we even start when we suspect DPLD? Well, the key, like with so many things in medicine, is just having a solid, systematic approach.
Your whole workup really comes down to these three things. It all starts at the bedside, right? A super detailed history, asking about their jobs, their hobbies, every single medicine they're on, family history, all of it. Then, we figure out the physiology with a full set of PFTs. And finally, we get our eyes on the lung architecture itself with an HRCT.
And listen, this point is so important, I can't stress it enough. You might get a chest x-ray first, sure, but a normal x-ray does not rule out DPLD. The HRCT is the gold standard, period. Those super thin slices give you that detailed view of the interstitium you need to spot things like ground glass changes, or reticulation, or even honeycombing.
Now, this right here, this is the single most important question that's going to shape your entire diagnostic process. The second you start thinking DPLD, your brain should immediately hit this fork in the road. Posing this simple question is what's going to keep you from getting totally lost in a sea of acronyms and rare diseases.
All right, so let's head down that first path. The DPLDs with a known cause. We always start here because, well, this is our best shot at finding a trigger we can actually treat or get rid of.
And this table really organizes the big culprits you need to think about. You have to be a detective. Go through that med list. Are they on amiodarone? You have to ask about smoking. You've got to screen for connective tissue diseases. And you need to really dig for environmental exposures, things like birds or mold, which could point you towards hypersensitivity pneumonitis. I know this sounds incredibly obvious, but it's such a high-yield point. For diseases like RBILD or DIP, which you pretty much only see in smokers, the single most powerful thing we can do for that patient is help them quit smoking. It's everything.
And this is exactly why you cannot skip that rheumatologic review of systems. Sometimes the lung problem is the very first sign of an underlying disease like rheumatoid arthritis or scleroderma. This is especially true if your patient is on the younger side. That's why screening labs like an ANA and an RF are part of a standard workup for a new DPLD.
Okay, but what if you've done all that detective work? You've ruled out all the known causes, and you're still coming up empty. Well, now you're heading down the other path, the idiopathic interstitial pneumonitis, or IIPs. And this is where recognizing patterns on that HRCT becomes absolutely essential. Putting these two side by side is so important. IPF is the most common and, unfortunately, the most deadly of the IIPs. It usually hits older patients, and the classic sign on the HRCT is that honeycombing pattern down at the lung basis. On the other hand, NSIP often shows up in younger folks. You see more ground glass on the CT, and thankfully, it carries a much better prognosis. Telling them apart is a huge deal for how you counsel patients and what treatments you offer. And we can't forget the great pretender, sarcoidosis. Its cause is unknown, but it's this really unique disease where the body forms these little clumps of inflammatory cells called granulomas. You always have to be looking for clues like hilar lymphadenopathy. Those big swollen lymph nodes right in the middle of the chest on an image, that should make you think of sarcoidosis right away.
Whew! Okay, that was a lot. So let's boil it all down into 4 key points that you can take with you on your next rotation.
Number 1, just be able to recognize the classic presentation when it walks in the door. The minute you hear short of breath with activity and dry cough that's been going on for weeks or months, that DPLD bell should be ringing in your head. Number 2, don't just order basic spirometry. You need the whole story. That means getting lung volumes, which will usually show you that restrictive pattern, and the DLCO,
the diffusion capacity. That DLCO is almost always going to be low because the scarring is messing with gas exchange.
Third, and yeah, we're saying it again because it's that important. Do not let a normal chest X-ray trick you into stopping the workup. If you have a high clinical suspicion from the story, the exam, and the PFTs, that patient needs an HRCT. No question.
And finally, number 4. For those DPLDs where we can find a cause, remember the treatment is all about getting rid of the trigger. With hypersensitivity pneumonitis, for example, no amount of medication is going to help if the person is still being exposed to the bird dander or the mold that's causing the whole problem in the first place.
So look, the goal here is to get you beyond just trying to memorize a giant list of diseases. By using this framework, starting with the presentation, using your toolkit of PFTs and HRCT, and always asking that key question, is the cause known or unknown, you can bring a logical, effective, and much less intimidating approach to your next patient with DPLD.